Recent papers have shown that amongst practicing trainee doctors and nurses, there is a lack of knowledge of oxygen therapy devices and their correct use. There are also many false beliefs regarding oxygen therapy, with the result that many patients on general wards are incorrectly treated. The following material describes the main types of device commonly used for delivering oxygen therapy. We hope this will increase the level of knowledge in this important discipline. The presentation is divided into three sections: oxygen therapy devices, how they work and what FiO2 can be achieved; humidification; definitions, indications, precautions, and the possible complications of oxygen therapy. Oxygen therapy devices, how they work and what FiO2 can be achieved. The devices for delivery of oxygen can be divided into two categories depending on whether they deliver a proportion or all of the patient's ventilatory requirement. Low-flow devices, also known as variable performance devices, deliver oxygen at flows lower than the patient's inspiratory requirements, so additional room air is also breathed in. High-flow devices, also known as fixed performance devices, deliver flows that meet the patient's total inspiratory requirements. Looking first at low-flow devices, let's look at the various device options that are available. Nasal cannulae are one of the most common ways of delivering oxygen therapy. A nasal cannula consists of two soft prongs attached to the oxygen supply tubing. The prongs are inserted into the patient's nostrils. The tubing is looped over the patient's ears, and the toggle is adjusted to ensure a good fit. Oxygen flows from the cannula into the patient's nasopharynx, which acts as an anatomic reservoir. Oxygen can be administered at 6 litres per minute or less. Flow rates of 4 litres per minute or less do not need to be humidified. Can be used at very low flow rates with children. Lightweight and generally comfortable. Patients are able to eat, drink and speak. Mouth breathers can benefit from this device. Needs upper airway to be free of obstruction. Are available with different prong shapes. The concentration of oxygen received by the patient will vary as previously mentioned. However, oxygen flows of 1 to 6 litres per minute will deliver up to 44% of oxygen to most adult patients. There are various sizes available for adults, pediatrics and neonates, and a variety of prong shapes are also available to suit varying circumstances. Straight prongs are the original design, and these are still the most frequently used in hospitals. Curved prongs are designed to direct the flow of oxygen posteriorly rather than upward towards the frontal sinuses. Flared prongs have an increased diameter towards the tip. This has the effect of slowing down the gas as it enters the nose, making it more comfortable for the patient. Curved and flared prongs combine the best features of the two options, releasing oxygen more slowly and away from the frontal sinuses. Caution: nasal cannulae are contraindicated in patients with nasal obstruction, for example nasal polyps. Medium concentration face masks provide another option for the delivery of low-flow oxygen therapy. These may be used for concentrations higher than those that can be achieved with nasal cannula, or when the nostrils are unavailable. The concentration of oxygen received by the patient will vary. However, as a guideline, 5 to 8 litres per minute will deliver between 35 to 50% FiO2 to most adult patients. There are a variety of sizes for adults, small adults and children. Some masks have nose clips to improve the mask fit. Designs are available with ear loops, which make it unnecessary to lift the patient's head when fitting. One end of the oxygen tube is attached to the spigot on the mask and the other to the oxygen flow meter. The flow meter is set to give the prescribed oxygen concentration. The mask is then fitted over the patient's nose and mouth, and the elastic tightened to give a secure, comfortable fit. If the mask has a nose clip, it is pinched to provide the best possible fit. Caution: flow must be at least 5 litres per minute to wash CO2 out of the mask and prevent rebreathing. Aspiration of vomitus is more likely when a mask is in place. High concentration masks. Non-rebreathing mask. This mask is usually used when high concentrations of oxygen are required. For example, with the critically ill or unstable patient. The patient breathes from the mask and the inspiratory valve opens so that oxygen is taken from the reservoir bag and the patient does not breathe room air. The patient breathes out through the expiratory valve. As the Eco High Concentration mask has a much improved fit, 2 safety valves are included. These allow the patient to breathe room air if the oxygen supply should fail. In reality, this type of mask delivers up to 80% oxygen with flows between 10 and 15 litres per minute. The fit of the mask and the patient's breathing pattern affect the amount of room air entrained and the oxygen concentration delivered. When using the non-rebreathing mask, first attach the oxygen tubing to the oxygen flow meter and set the flow rate to 15 litres per minute. Occlude the inspiratory valve, being careful not to damage the valve, and allow the reservoir bag to fill. Squeeze the reservoir bag to test the patency of the valve between the reservoir bag and the mask. If the reservoir will not empty, discard the mask, choose another, and test again. Place the mask on the patient's face, obtaining as tight a fit as possible. Adjust the oxygen flow rate so that the bag deflates by about 1/3 with each breath. Caution: flows must always be high enough to ensure that the reservoir bag does not empty completely at the end of inspiration. Minimum flow 10 litres per minute. Aspiration of vomitus is more likely when a mask is in place. Now let's look at the high flow devices. These provide sufficient flow of gas to meet all of the patient's minute ventilation requirements. Let's look at when a high flow device might be more appropriate. Patients with chronic lung disease and CO2 retention whose ventilation is dependent on hypoxic drive. This is an overemphasized condition in which the usual stimulus for respiration, maintenance of a normal CO2, is lost due to chronically high CO2 levels. Respiration is then driven by hypoxia. If high concentrations of oxygen are given to these patients and their PaO2 goes up too much, this hypoxic respiratory drive can be lost. Hypoventilation may occur and the CO2 will become very high, causing coma and possibly death. In this instance, a high-flow device in which the oxygen concentration can be carefully controlled and guided by blood gas measurements is more appropriate. The inspired oxygen concentration is determined by the design of the device and not by the patient's rate and depth of breathing. Clinically, Venturi devices are used to increase gas flow to the patient because air can be entrained using the Venturi principle. These devices can be used to deliver accurate oxygen concentrations by mixing air with oxygen. High-flow devices maintain a constant delivery of inspired oxygen concentration throughout the respiratory cycle. Masks are available which deliver a single concentration of oxygen, for example 24%. These are also available with interchangeable colour-coded Venturi valves for different concentrations. When using a Venturi mask, select a Venturi valve of the prescribed oxygen concentration and attach it to the mask. Attach one end of the oxygen tubing to the valve spigot and the other end to the oxygen flow meter. Set the flow meter to the flow indicated on the valve. Place the mask over the patient's nose and mouth and tighten the elastic to obtain a secure and comfortable fit. If the mask has a nose clip, it should be pinched to provide the best possible fit. Caution: at oxygen requirements above 40%, the valve may not generate enough total flow to meet high inspiratory demands. There is a widespread misconception that the oxygen concentration varies with the oxygen flow rate. If the oxygen flow rate is increased, the total flow to the patient is increased, but the concentration stays the same. Fixed Venturi valves can also be incorporated into oxygen recovery T-piece kits. The most popular is the 40% valve. These are used to provide spontaneously breathing, intubated patients with supplementary oxygen during transport and in the recovery room. Connect the T-piece to the 15mm connector of the tracheal tube or laryngeal mask airway. Attach one end of the oxygen tubing to the valve spigot and the other to the oxygen flow meter. Set the flow meter to the flow indicated on the valve. A disadvantage of fixed concentration Venturi valves is that in order to change the concentration delivered to the patient, it is necessary to change the valve. This can be overcome by using an adjustable Venturi valve. With an adjustable Venturi valve, the rotation of the sleeve increases or decreases the size of the air entrainment window. This in turn changes the oxygen concentration. This means that the same valve can deliver a wide range of concentrations. As the valve does not have to be replaced each time the prescribed oxygen concentration changes, the changes can be made quickly. It also means that different valves do not have to be held in stock by the hospital. The Silente adjustable Venturi can be set to concentrations between 26 and 50%. And incorporates a twist lock mechanism to prevent inadvertent concentration changes. As with a fixed valve, attach one end of the oxygen tubing to the valve spigot and the other to the oxygen flow meter. To select the desired oxygen concentration, ensure the range selector sleeve is in the appropriate position. If the desired concentration is in the 26 to 35% range, then ensure the range selector is in the white area. If the desired concentration is in the 40 to 50% range, then rotate the oxygen concentration selector to 35%. Pull and rotate the oxygen range selector to the purple area. Select the desired oxygen setting by rotating the oxygen adjuster. Set the oxygen flow meter to the flow indicated adjacent to the oxygen concentration. The materials used in the manufacture of eco-range oxygen therapy masks mean that there is a significantly lower impact on the environment. They also have a new lightweight design, incorporating a soft face seal that provides a high level of patient comfort. This section covers the type of humidifier that delivers cool humidification. Fink and Hunt in Clinical Practice in Respiratory Care describe the two most commonly used devices in this category as follows. A humidifier is a device that adds molecular water to gas, whereas a nebulizer produces an aerosol or suspension of particles in gas. Bubble humidifiers use the bubble-through humidification process to bring dry oxygen gas to ambient levels of humidity. The gas is directed into the water bottle where it is broken up into small bubbles. These gain humidity as they rise to the surface of the water. The absolute humidity of the gas varies with flow rate, water temperature, bottle size, and volume of water in the bottle. Bubble humidifiers are most commonly used with low-flow devices such as nasal cannulae and medium concentration oxygen masks. Some models incorporate a pressure relief valve designed to prevent excessive pressures building up in the bottle should the oxygen tubing become occluded. Operation of the relief valve may also activate an audible warning, drawing the attention of the user to this problem. The head of the bubble humidifier may also incorporate a universal screw thread. This permits the use of a bottle, which can be refilled with sterile water, or the use of pre-filled sterile water bottles. The flow meter should be attached to an appropriate oxygen supply. Fill the bottle with sterile water using an aseptic technique and fit the humidifier head or fit a pre-filled sterile water bottle. The humidifier should then be attached to the flow meter. Adjust the flow meter to 4 litres per minute and occlude the outlet. Verify that the relief valve operates within 5 seconds. Reset the oxygen flow meter to the appropriate flow for the patient. Attach the delivery device and fit to the patient. The other method of delivering cold humidification is by using a humidifier nebulizer. Humidifier nebulizers use the Venturi principle to create a low pressure area at the end of a tube. The other end of the tube extends into a bottle containing sterile water. Water is drawn up the tube and is broken into an aerosol of small droplets by the oxygen stream. This same low pressure area also entrains air from the atmosphere to dilute the oxygen to the desired level. The air-oxygen mixture containing the water droplets then passes to the patient. Humidifier nebulizers can deliver between 24 and 50 milligrams of water per litre of gas depending on the flow setting. Humidifier nebulizers are most commonly used with devices such as aerosol and tracheostomy masks. It is important that these devices operate as quietly as possible to ensure a comfortable environment for the patient. They should also conform to international standards to ensure that the oxygen concentrations are delivered accurately. Some devices are fitted with a tamper-proof control to prevent inadvertent changes to oxygen concentrations. As with bubble humidifiers, the head of the nebulizer humidifier may also incorporate a universal screw thread. This permits the use of a bottle, which can be refilled with sterile water, or the use of pre-filled sterile water bottles. The flow meter should be attached to an appropriate oxygen supply. Fill the bottle with sterile water using an aseptic technique and fit to the humidifier head or fit a pre-filled sterile water bottle. The humidifier nebulizer should then be attached to the flow meter. Attach 22 mm flex tube to the outlet of the humidifier nebulizer. Position the tubing so that the lowest point is below the patient. This is to prevent any condensed water from running into the patient. Attach the mask. Adjust the oxygen concentration to the required level. Set the flow meter to provide the required total flow to the patient. The Intersurgical Aqua Mist makes this simple by indicating the appropriate flow above each oxygen setting. Attach the delivery device and fit to the patient. There is no universal standard for flow meter connections, and they can vary by country. The Aquaflow and Aqua Mist both incorporate a DISS oxygen connection, which is the most common type. A number of flow meter adapters are available to fit other types of flow meter. For example, the M12. Caution: these devices should not be used in ventilator circuits, as the air entrainment port will introduce a leak into the system. These devices should only be filled with sterile fluids that are changed every day. Any residual fluid should be drained from the bottle and discarded before refilling. It is important that the lowest point of the flex tube is lower than the patient and that any condensate is regularly drained to prevent this entering the patient or occluding the flex tube. It may be helpful to emphasize some important points regarding oxygen therapy. All critically ill patients require oxygen. Central cyanosis is caused by both cardiac and pulmonary disease. Peripheral cyanosis results from a sluggish peripheral circulation, as in hypervolemia, cardiogenic shock, a cold environment, and arterial or venous obstruction. Hyperventilation and disorders affecting ventilation-perfusion matching are the most frequent acute causes of cyanosis seen in acute emergencies. High concentrations of inspired oxygen do not depress ventilation in patients with acute respiratory failure. Oxygen therapy must be prescribed. Oxygen therapy must be monitored. Patients do not die from a raised carbon dioxide level alone. They die from hypoxemia. Pulse oximeters measure oxygenation, not ventilation. Definitions, indications, precautions and possible complications of oxygen therapy. Indications for oxygen therapy include documented hypoxemia. This is defined as decreased PaO2 in the blood below normal range. A PaO2 of less than 60 torr or SaO2 of less than 90% in patients breathing room air, or with a PaO2 and/or SaO2 below the desired range for a specific clinical situation. In an acute care situation in which hypoxemia is suspected, substantiation of hypoxemia is required within an appropriate period of time following the initiation of therapy. Severe trauma, an acute myocardial infarction, short-term therapy or surgical intervention, for example, post-anesthesia recovery. Precautions and possible complications. With a PaO2 greater or equal to 60 torr, ventilatory depression may occur in spontaneously breathing patients with an elevated PaCO2. With FiO2 greater or equal to 0.5, absorption atelectasis, oxygen toxicity, and/or depression of ciliary and/or leukocytic function may occur. The administration of supplemental oxygen to patients with chronic CO2 retention may result in a decrease in respiratory drive. Supplemental oxygen should be administered with caution to patients suffering from paraquat poisoning and to patients receiving bleomycin. During laser bronchoscopy, minimum levels of supplemental oxygen should be used to avoid intratracheal ignition. Fire hazard is increased in the presence of increased oxygen concentrations. Bacterial contamination associated with certain nebulization and humidification systems is a possible hazard. Limitations of procedure. Oxygen therapy has only limited benefit for the treatment of hypoxia due to anemia, and benefit may be limited with ventilatory disturbances. Oxygen therapy should not be used in lieu of, but in addition to, mechanical ventilation when ventilator support is indicated.